increased in the certain urban areas over the past 40 years. Bardell publication in 2003 demonstrated a large increase in the Camberwell between 65 in Camberwell between 65 and 97 using a case record analysis. The male to a female difference in the incidence of schizophrenia is estimated to be around 1.4 as to 1. So it's again male predominant here, with more males being diagnosed with the disease. The male excess persistence, even when factors such as age range and diagnostic criteria are taken into account. Definitely, it's a bit higher in male, the prevalence. The median prevalence of schizophrenia is estimated to be 4.6 per thousand for point prevalence and 3.3 per thousand for period prevalence. So point prevalence, period prevalence, and then 4.0 per, so that's 4 per thousand for lifetime prevalence, and not 1% as quoted by Jason Manuel. Yeah, because I was just about to come to this. Like, I know it's 1% somewhere quoted. Anyone has a better, like, so what do we answer? That's what I'm saying. Like, if it's an exam question about the prevalence, do we say just 1% or we?
Yesterday there was an MCQ.
Yeah.
I am new to the group, but there was an MCQ in another group, and there the answer of SPMM was 1 for schizophrenia.
Exactly, yeah. And now this,
and male female the ratio was also equal in adults for schizophrenia.
So maybe I think we'll come across as we read those figures, because here they're saying that it's not 1%. It's they gave like point prevalence, period prevalence, and lifetime prevalence. I mean, I know that lifetime prevalence is 1%. That's what I remember from paper A. But then, okay, we'll just keep reading, and maybe we'll come across.
Yeah.
So and 7.2 per thousand for the lifetime morbid risk. This is like 2004 information data. There were no significant difference between the males and females here, as you pointed out, right? Because before it was right 1.4 as to 1. This was the data between 65 and 97. This is from 2004. Between urban, rural, and mixed sites. All the migrants and homeless people had a higher rate of schizophrenia. And not surprisingly, developing countries had lower prevalence rates. Yeah, so developing countries had lower prevalence rate, whereas developed country had higher, as previously documented. As it is well known, the outcome is better in developing nations. Point prevalence must be low as a corollary. As it was shown by Sahatal, off-note catatonia was 10% in developing versus 1% in the developed nations. So catatonia, higher catatonia in amongst the developing nations, and then heaviphrenia was 13% in developed and 4% in developing nations. So basically, they're trying to say developed have more disorganized schizophrenia, whereas more catatonia was seen in developing nations. I think that's the information here. AESOP study concluded that all psychosis are more common in the black and the minority ethnic groups compared to the white population of Bristol, Southeast London, Nottingham. That also differences in the age accounted for approximately a quarter of this effect. The age-sex standardization incidence rate for all psychosis was higher in Southeast London, the Nottingham or Bristol. These are the figures. I'm not sure they will be keen to ask this. Surveys of psychotic symptoms in general population, 2000 psychiatric morbidity survey from apparently healthy individuals in private households revealed that 5.5% endorse that at least one psychosis items is in a validated questionnaire. 4.2% endorse hallucination items. This 4.2 of the sample said that there had been a time where they heard or saw things that other people could not, but only 0.7% reported hearing voices, saying quite a few words or a sentence when there was no one around that might account for it. While 4% of white British sample endorsed the hallucination question, hallucinations were 2.5-fold higher in a Caribbean sample and half as a common in South Asian sample. So that's a survey. So they're saying coincidence higher. Okay, anyone can help me reading the table? It will be quicker. They're saying coincidence, prevalence, and standardized mortality. Okay, this is by Margaret study, right? And they're saying so it's the incidence, prevalence, and then mortality rate. Okay, so they're saying incidence was higher amongst the male, whereas prevalence and prevalence was equal amongst the both, and mortality amongst was same. Migration status: migrants had more incident and more prevalence, and no data available about the morbidity. Then urbanicity, so urban living, higher incidence was more in urban living as compared to the rural or mixed, and then prevalence was equal. Again, prevalence equal here. The prevalence also gender, male and female is equal. Then trend falling over the time. That means incidence are falling over the time. They're saying prevalence is stable, and then mortality is rising. And economic status, they again said that the incidence is equal in developed and less developed countries, whereas prevalence is higher in the developed nations. And they quoted the reason for the same as well. And then standardized mortality is also equal. And then latitude is it's high. Even what is latitude here? Like, what do they mean by latitude? They're talking about severity of symptoms or something. Latitude.
Like away from the equator, sir.
Away from equator. Okay. So.
Hello.
So. Okay, and that's why they are looking at the prevalence.
Yeah, the incidence and
okay, so high and
yeah, both is high as we go away from the equator.
Okay, yeah, and then lower latitude in males, and then lower. Yeah, I don't know why there's a word males here. It's not here, but basically we're trying to say that if you're away from the equator.
If we are away from equator, there is a higher rate of incidence and prevalence of schizophrenia in males.
Okay, let's assume it like that.
Yeah.
The more you're away. Okay, thank you. Thank you. Okay, next is high risk prediction studies in schizophrenia. It is thought that the individuals at enhanced genetic risk of schizophrenia. There's a family history inherit a state of vulnerability characterized by the transient and a partial psychosis-like symptoms, but not all of these are developed for schizophrenia. According to the Edinburgh high risk study, the 10% risk present in those with high risk history of increase in nearly 50% in those subgroup who have high score on schizotypal cognition and social withdrawal characteristic by introversion and anxiety. Measures of episodic memory are also proposed to be significantly discriminating between those with high risk who develop schizophrenia from those who do not. This is suggestive of temporal lobe dysfunction. It is also shown that the temporal lobe volume deteriorates with the passage of the time in those with psychotic symptoms, and this is controversial. And Australian PACE clinic sample 20 of 49 ultra high risk subjects, that's 40%, 40.8% developed a psychotic disorder within 12 months. So they're talking about ultra high risk. So 50-50. Some highly significant predictors of psychosis were found: long duration of the prodromal symptoms, poor functioning and at intake, low-grade psychotic symptoms, depression, and disorganization. The German sample using a Bonn basic symptom criteria at a very high conversion rate was seen in help-seeking individuals in a long follow-up period of nearly 10 years. The Bonn scale has 5 symptoms clusters, of which the presence of thought, language, perception, and motor disturbances showed a significantly greater predictive discrimination than any other cluster. The NAPLS, North American Prodrome Longitudinal Study, the ultra-high risk UHR criteria predict an early transition to psychosis with a huge risk of 405 compared with 405? 405 compared with the incidence rate of the psychotic. Sorry, what is this 405? Risk of 405? Maybe is it a percentile or something? With the incidence rate of psychotic disorders in general population, the predictive power can be enhanced by the use of the key variables such as genetic risk, functional impairment, and higher level of psychopathology at baseline, especially odd beliefs or suspiciousness. Substance use, but not a specific class of substance per se, also increase the predictive value, but the 3 former variables together nearly double the predictive power. Okay, that's that. Now they move to delusional disorders. Incidence is 0.7 to 1.3 per 100,000, and prevalence is high, 24 to 30 per 100,000. Proportion of the hospital first admission cases 1 to 3%, mean age of onset 39 years, and sex ratio is 1.18 as to 1. So again, here's a male predominant, and the studies from 82 and 66. Outcome of schizophrenia. I don't know why they give the table of delusional disorder. How relevant is the table? Anyways, so from the schizophrenia, very long-term follow-up generally suggest a more favorable outcome that was assumed by practicing clinicians. In the Iowa study, 186 persons with schizophrenia were followed up for average 35 years, excluding affective or schizoaffective disorders. 46% of those people with schizophrenia had improved or recovered. The Bonn Hospital study, again, Germany, followed 502 persons with schizophrenia for an average 22.4 years. The result were 22% of the research participants had complete remission of symptoms, and 43% of non-characteristic types of remission defined as involving non-psychotic symptoms only. And 35% experienced characteristic schizophrenia residual symptoms, so 35%. Therefore, 65% had a more favorable outcome than would have been expected from clinical experience. In a Chestnut Lodge study, 6 patients were followed up on average 15 years. 1/3, 36% were recovered, strict recovery criteria or functioning adequately. In Vermont longitudinal study, 68% of the patients, that sample size of 269, follow-up average is 32 years, who underwent rehab program, had good functioning as determined by GAF scale. Yeah, so they're showing the recovery there. Then International Study of Schizophrenia by WHO reported on follow-up analysis of 2 major WHO incident cohorts. First cohort was a part of IPSS, International Pilot Study of Schizophrenia, while the second cohort was from the determinants of outcome of severe mental disorder and reduction of disability study, which followed IPSS with a more rigorous method of outcome measurement. Sample size of 1202 from 9 countries. In total, 52% of persons in developing countries. For example, Colombia, India, and Nigeria. were assessed to be the best outcome category, defined as a single episode only, followed by the full partial recovery, compared to 39% of the developed countries. So, yeah, so better recovery, they're saying in the international study. And developed countries include Moscow, London, Washington, Prague, Arctus, and Denmark. In a 5-year follow-up, 73% of those participants from a developing world were in the best outcome group compared to the 52% developed world. So it's a better recovery, 73 versus 52%, developed versus developing nations, compared to the 52% of the developed world. So DOSMED use more rigorous criteria and followed more than 1,300 patients in 10 countries, and similar to the IPSS, discovered the highest rate of recovery outcome in a developing world. Yeah, I think they're just trying to reiterate that developing world will have a better outcome as per these studies. DOSMED excluded mode of onset being